Good evening. My name is Jean-Claude Tardif. I am from the Montreal Heart Institute. On behalf of our colleagues at NYU Langone, we're pleased to welcome you to this webinar entitled, Can We Reduce or Prevent the Complications of COVID-19? People are entering the webinar as we speak, so we'll give them a few seconds. We have a wonderful program for you this evening. We have two presentations, formal presentations. Then Dr. Michael Pillinger will handle the comment, question and answer period. We will try to limit this to 45 minutes. We do realize that you're all busy and that you have professional and personal tasks, so we're going to try to limit this to 45 minutes. You will be able to ask your questions in the chat room. Again, Dr. Pillinger will handle them. And as I see more people joining, we will start in a few seconds. So allow me to introduce our first speaker, Dr. Vin Pham, is section chief for infectious disease at New York University Langone Orthopedic Hospital. He is also the director of the antibiotic stewardship program at NYU Langone Health, and his talk this evening is entitled The Science of SARS-CoV-2, COVID-19, and I turn it to Dr. Pham. Dr. Pham, please ensure that you're not muted, and we're looking forward to your talk.
Okay. Greetings. Can you hear me now? I apologize for that.
We can hear you very well.
Great. Are you able to see these slides?
Not yet, I believe.
Okay. Apologies. Let me...
Dr. Pham, you want to start your video, I think.
Okay, let me do that. Apologies here. Do you see the slides now?
We see you, Dr. Pham.
Okay, apologies again. I'm going to share screen. Okay, screen sharing is still disabled. So maybe we should revert over to having these.
Yeah, that's not a problem. So we will show you slides.
Great.
And there you go. You have them, and all you have to do is ask when you want the slides to be changed. So we're all looking forward to your talk about the science of SARS-CoV-2.
Great, thank you. So thank you again for the introduction. And without further ado, if you could just go to the next slide. Very, very quickly, I don't have any financial disclosures to make, but I will. I do have to note that due to the nature of this illness, that I will be mentioning at least some non-FDA approved therapeutics and diagnostics. My background was already mentioned. Just as a disclosure, another disclosure is that my career has been a little bit all over the place. So my background actually started in molecular parasitology in the laboratory. As a clinician, I have a lot of years of experience taking care of persons with hepatitis B and hepatitis C in particular. But as many of us clinicians know, then we've all taken care of many, many patients with COVID-19 now. So what I'll try to do is kind of give an overview of some of the virologic aspects of the disease, and then leave the immunology for true immunology experts. So if you could go to the next slide, please. Why are we always having these discussions about COVID-19? Why so many webinars, panels, et cetera? It's because there's so much that we're still discovering about it. It is a novel disease. It is a novel virus. There have been some related viruses that have preceded it, and we'll discuss those a little bit, but we're still learning a lot about every aspect of this virus, its biology, including its genetics, its biochemistry, the ecology and epidemiology of the disease, the clinical course, how to treat these patients, how to diagnose it, and the long-term questions of is there going to be lasting immunity, and what does that mean for therapeutics and prevention. If you could go to the next slide, please. The coronaviruses are so named, as many of you know, because of the protuberant spike protein, which is on the membrane of the virus. And on electron microscopy, then it gave it this pattern that reminded the discoverers of a crown, hence the name. The spike protein is quite important because it is the protein that is used for viral entry. So that is how the virus invades the cells. The other proteins and other components of the virion particle are shown there, and a map, genetic map as an overview is shown at the bottom. If you can go to the next slide, please. I am, as I mentioned, a parasitologist by training, so I'm sorry, but I can't help but present the life cycle for everybody. But the main point here is that it is an RNA virus. It does not make a permanent copy of itself in cells as some other viruses do. For example, HIV, which is a retrovirus, and hepatitis B, which makes an episome, which can persist in the nuclei of infected cells. This virus spends its entire life cycle in the cytoplasm. All the steps of its replication occur there. And so many of the targets of antiviral therapy are occurring to target these different steps of its life cycle. The way that the virus actually enters the cell is also of interest. Again, it is that spike protein, which is often abbreviated as S protein, that binds to in the case of human beings, the ACE2 receptor. I'll talk about that a little bit more. And the act of binding and then membrane fusion does involve a few steps, and that also presents a potential target for therapeutics. If you go to the next slide, please. So here's a phylogenetic schematic of the different coronaviruses. It's worth noting that there are several coronaviruses that infect human beings that we are now aware of. Several of these cause mild symptoms, and for clinicians in the audience, then you're probably familiar with these coronaviruses because they're often in commercially available multiplex panels looking at respiratory pathogens. The more recently recognized coronaviruses that cause severe disease in human beings, namely SARS, which first emerged in 2002, MERS, which first emerged in 2012, and then now the 2019 novel coronavirus, also known now as SARS-CoV-2. These viruses are more closely related to each other than to the other coronaviruses, and they are in the group known as the beta coronaviruses. If you go to the next slide, please. Where did they come from? So this is a matter of great interest, because obviously if we know where they come from, then it might help us to think about prevention of this in the future. This is one of many zoonotic infections. In other words, it circulates already in animals. Those are their main hosts, but can cause infection in human beings. SARS, the original SARS, was noted to be transmitted to human beings. There's evidence that it was from the civet cat, so-called civet cat, but ultimately the original hosts are bats. And it turns out that bats are great hosts for coronaviruses in general. They have many, many, many different types of coronaviruses. The ones that we are familiar with as human beings are the ones that have made this leap through to us. But it is believed that for the most part, there is an intermediate host of some sort. The civet cat, as I mentioned, for SARS in 2002. More recently, camels being the intermediate host for MERS. In other words, the camels picked it up somehow, perhaps indirectly also, when it was originally from a bat. But then close human interactions with camels and civet cats, we believe is the reason why human beings were then picking up the disease, and then from there transmitted to other human beings. This novel virus, SARS-CoV-2, its intermediate host has not been definitively identified. There's some speculation that it might be a pangolin, but that has not been proven yet. So this is one of the many unknowns that we are still grappling with. If you could go to the next slide, please. Now, as one can imagine, since there are many different intermediate hosts before they get to human beings, then not surprisingly, it's a reflection of the fact that these viruses can have different receptors that they use to invade the host cell. As I already mentioned, for SARS-CoV-2, then that receptor is the ACE2 receptor, which is found in lung cells, pulmonary epithelial cells, which is believed to correspond or in part explain the nature of the disease that it causes. That is still subject of intense investigation. And it may also relate to the presence of coronavirus and other bodily fluids or body anatomic locations. Similarly, SARS-CoV from 2002 also used the ACE2 receptor. The receptor for MERS-CoV is different. If you could go to the next slide, please. So as I mentioned, different receptors for the different viruses, although SARS-CoV and SARS-CoV-2 are very closely related, so they do use the same receptor. Another difference, though, clinically, as folks are probably aware, are the different case fatality rates that have been reported. Big caveat here, there's a lot of debate over how to accurately calculate these. It depends a lot on who gets tested and whether you include people who only have laboratory confirmed diagnoses or people who, for whom there's no laboratory confirmation but a high suspicion of the death being caused by the infection, or even looking at excess deaths in a specific geographic location as compared to prior years' expected fatalities. Anyway, looking at these numbers in a variety of different ways, it still appears that the case fatality rate for SARS-CoV-2 is much lower than it was for SARS back in 2002 through 2004, and more recently MERS. And this is a good thing, of course. In other words, if one gets this infection, it appears that one is much less likely to have a fatal outcome as compared to those other two diseases. On the other hand, that may account for its higher transmission rate, that famous R that everyone's talking about, in part because a highly pathogenic microbe, if it kills its host very efficiently and very quickly, actually limits its ability to spread to other people. So unfortunately for us, SARS-CoV-2 appears to have hit that sweet spot of being highly transmissible and also deadly, but not so deadly that it affects, that it seems to be slowing down its transmission. And that is probably why it is, in part, why it is a pandemic disease, and the other two have not been. Next slide, please. Big question that arises is where is this virus found in anatomic locations and body fluids? This has a lot of implications, as one can imagine, for prevention and control measures. And not surprisingly, again, it is a respiratory infection. The human coronaviruses, all of them that we've discussed are considered largely respiratory pathogens. And so they are found in nasopharyngeal secretions, and also sputum, so deep lung secretions as well. The deep lung secretions is a reasonable reflection of the fact that SARS-CoV-2 can cause lower respiratory tract disease and not just upper respiratory tract infection, aka common cold. So that is not surprising. It has been identified also in stool, which is also not surprising because that is also the case for SARS. Back in 2002, 2004. But unlike the first SARS, to date, this has not been shown to be a major means of transmission. We may not have discovered it yet, or we just may not have recognized it, but it does not appear to be a major route of transmission as it appears to have been for SARS back in 2002 through 2004. So that is why when you hear in the news about the WHO's and the CDC's recommendations about how to protect yourself and protect others, it is related largely to the expulsion of droplets from our airway if we have the infection, and also preventing the inhalation of so-called airborne particles under certain circumstances where those particles are felt to exist. I won't go into that into too much detail because that is a lengthy discussion of what airborne actually means. It actually means something different to infection prevention control people than it does to the general public. Next slide, please. Now, big point I wanted to make was that even though, as you can see from the column second from the right, that we can often find a persistent signal on detection of nucleic acids for a very, very long time, in nasopharyngeal or upper respiratory or lower respiratory secretions. Interestingly, there's been a failure so far, in spite of multiple attempts from multiple laboratories in multiple countries, to isolate viable infectious pathogen beyond a week or 10 days, perhaps. It's not quite clear. So in other words, even though we are still getting that positive detection of nucleic acid, that may not actually indicate that the person is still contagious to other people. And as I mentioned, that can be very important in terms of coming up with recommendations about when people can stop their quarantine, when people can come back to work, and also from us as epidemiologists or as clinicians thinking about, is this person at risk if they were exposed to somebody a month ago, but they didn't have any symptoms since then? What's the likelihood that they may still be shedding? So these are some of the scientific questions that are still being worked on. We don't have all the answers yet, but that is the way the evidence is going. Next slide, please. Oh, sorry about that. Next slide, please. Okay, so very quick, I'll just summarize some of the investigational therapeutics and diagnostics. I want to stress that these are all investigational. There are no agents yet, no therapeutic agents yet that have been FDA approved, nor are there any diagnostic tests that have been FDA approved in the United States. All of these products, including the diagnostic testing, are being used under so-called emergency use authorizations. So in other words, there is a minimum amount of data available to the properties of the test or the agent in question, but they have not met that rigorous standard for full FDA approval. Trials are ongoing for all the therapeutics that I'm going to discuss, and the manufacturers of diagnostics are expected to accumulate their validation data. So some of these therapeutics and some of these diagnostics may not make it in the end. That's something very clear to understand. And it also means that we're still learning about how to use these therapeutics, which of them work, which of them may cause harm, and the diagnostics as well, how to interpret the results. What do they mean for us, for ourselves and for our patients? Next slide, please. So very, very quickly, I'm not going to talk about any of these in detail because, again, they're all investigational. This is only a partial list of what's out there, but these are some of the agents that you've probably heard about. Remdesivir has had some preliminary data released. Just as a disclosure, our institution, NYU, is involved with some of the clinical work on remdesivir. But that, again, the trials are ongoing, and so we need more data to really know how well these agents work and their safety profiles. Convalescent, those antivirals, by the way, are all small molecules, and they target specific steps in the viral replication life cycle that I showed before. Also being studied is convalescent plasma as a therapeutic, and not surprisingly, there may be a role for the interferons as well. They have broad spectrum antiviral properties. Next slide, please. I'm not going to talk in detail about any of the immunologic therapeutics. These target processes in the host and not the virus. I defer to the discussion on the immune response. Next slide, please. Oops, I apologize. I can't quite see if the slide is showing properly. If you could actually advance again. There we go, sorry, okay. So as I mentioned, the life cycle indicates to us where these targets are. So some of these agents act on the cellular entry because they prevent that spike protein priming that I had mentioned. Some of them prevent the, they affect the autophagosome lysosome fusion step where the viral particle uncoats. And then others affect the genome replication directly. They basically inhibit the RNA-dependent RNA polymerase in a manner similar to some of the medicines used for hepatitis B and HIV. Next slide, please. Now, diagnostics, very quickly. Broken down into a few broad categories: those that try to detect the virus or some signal from it, and those that detect our immune response. So reverse transcriptase, polymerase chain reaction, RT-PCR, is the most commonly used modality. The body fluids that can be checked are shown there. Again, Data are limited so far, but studies are ongoing to look at the sensitivity and specificity in these different body fluid sources. They will vary based on the body fluid. More recently, there have been some products that are isothermal nucleic acid amplification. I'll talk about why that's different. Viral culture is the main, it's kind of the gold standard in terms of determining if a person still has infectious material, but that has its own issues. And then serologic testing, of course, looks again to see if we have antibodies to the virus. Next slide, please. So what are some of the issues? RT-PCR, like PCR in general, requires a thermal cycler. So that means that you need a specialty lab that has the capability of doing it. So that may limit access to this testing. PCR reactions are also very, very susceptible to contamination. So extremely careful specimen collection and handling is key. Hence the interest in isothermal nucleic acid amplification tests, which may be used at point of care. However, there are some concerns about test performances of some of the available products. I'm not going to go into that into detail. Viral culture, as I mentioned, is the one way to see if a person actually has infectious material. However, because of the nature of this virus and the disease it causes, it has to be done in a biosafety level 3 lab. There are only a limited number of them in the United States, and the work is dangerous. So that limits that as a diagnostic test. And then for serologies, well, again, this leads to our questions about immunology, the unknowns. When do the antibodies develop? What are the optimal titers? Do they actually confer immunity or not? And are they going to protect us if this virus continues to mutate, as evidence has suggested that it has already mutated as it is spread throughout the world? Next slide, please. Just to show you just one little nugget of information about using the polymerase chain reaction again to diagnose people. You can see varying numbers in terms of the calculated incidence rate in this table from the study. This is actually a review of the reports from these different clusters of outbreaks, basically. And you'll notice that for 2 of these clusters where a high level of testing was done. So in other words, everybody that they could possibly test was tested. Then the proportion of diagnoses that were made in persons who were asymptomatic was much, much higher. So in other words, that suggests that if you test enough people, you will find people who have the infection and yet they may be completely asymptomatic, in contrast to the critically ill people who have really taken the healthcare system to the limit. Next slide, please. So again, that's relevant to this slide that I showed you before, where if you advance the slide again, I highlight again the fact that the PCR assays can result in a positive signal for nucleic acid, even well beyond the point where we think that a person is still symptomatic, but it may also be a way to pick up asymptomatic people. The question is, how do we know when to test them? When do we screen people? How often do we have to rescreen them if that's a strategy? These are all unknown. So last slide. If you could advance the slide, please. Sorry, one more. Thank you. So it brings us back to, if you advance the slide, it brings us back again to the same questions that we had before. We've made a lot of advances. There's a lot of science that's being done now. Many clinical trials looking at these agents, but the final verdict is definitely not in yet. And as much as we've learned and how impressive the scientific effort has been, it's a reminder of how much more we need to learn. Thank you.
Thank you very much, Dr. Pham. This was a superb review. I would like to remind everyone that you can enter your questions in the chat room, and Dr. Pillinger, after the second talk, will be able to take them, address comments and questions. If I could have the first slide for my presentation. So, as you will remember, the title of the webinar was, can we reduce or prevent COVID-19 complications? And Dr. Pham reminded us that actually there are very limited tools we have now. We have remdesivir, which use is allowed in patients who are hospitalized. This is an IV medication. There was some use transiently of chloroquine and hydroxychloroquine, but with this recent large observational study of 100,000 patients published in the Lancet a few days ago. Really, it sent a cold shower on the use of hydroxychloroquine or chloroquine with an increased rate of arrhythmias and deaths. And as you know, the World Health Organization's Solidarity trial part that pertained to the use of chloroquine and hydroxychloroquine was at least stopped temporarily. So, and the use of these agents has been banned in France, for example. So you can go to the next slide. So as clinicians and patients, we all want to see what has potential to help our patients. And so I'm going to try to make the case, and with Dr. Benita Shah, who will speak in a few minutes, for the fact that preventing the so-called inflammatory storm might be a way to prevent some of the severe complications of COVID-19 until we have a vaccine. And we'll have to see, even if a day comes when we do have a vaccine, we'll have to see the actual protection that is offered and for how long this protection will be afforded. So let's start with a very simple observation. There's actually a common denominator between what was observed in the 1918 influenza Spanish flu pandemic and the current COVID-19 pandemic, and that is that children, while frequently infected, as you see here on this slide, actually very rarely get the severe complications. One might say, well, there might be some cases of complications associated in youngsters with Kawasaki disease, but there's certainly not these severe pneumonias and acute respiratory distress syndrome that are seen with COVID-19. And so I could have shown you a similar picture in the current COVID-19 pandemic, where children, again, are frequently infected but rarely get complications. And we believe we understand why this is the case. Next slide. Actually, we know that children are able to put the brakes, if you will, much faster on the inflammatory reaction than adults are. And perhaps the reason for that, without being too technical, we know that children, unlike adults, are able to produce an anti-inflammatory interleukin-10 dependent response, unlike adults. And you have here the response when you expose white blood cells of children or adults to an inflammatory stimulus. You see that the IL-10 anti-inflammatory response in children is much more marked than it is in adults. Why is that? Next slide. Well, it turns out, and I'm not asking you to look at all the details of this slide, but it turns out that this gene that produces interleukin-10, this anti-inflammatory cytokine, can actually be turned off by a process called methylation that occurs after puberty, but will become more marked as we get older. So the bottom line is, as you are aging, you are less able to recruit an IL-10 dependent anti-inflammatory reaction. Why is that important? Next slide. Well, it turns out that, and I will ask you just to focus on the right part of the slide. You see that in patients in red that are deficient in an IL-10 receptor or IL-10 dependent reaction, what will happen is that when you expose them to an inflammatory stimulus that is called LPS on this slide, their ability to produce an inflammatory reaction dependent on IL-1, interleukin-1, which is a pro-inflammatory cytokine, their ability to produce an inflammatory reaction is much more marked in red, as opposed to the control patients that actually produce very little IL-1 when exposed to LPS. IL-1 is sort of the typical interleukin that is produced by the inflammasome. Remember this word, the inflammasome is an organelle in the cells that is responsible for the production of some of these cytokines. Next slide. Now, why is that important? Is that actually SARS-CoV-1, the agent that was responsible for the SARS epidemic of 2003, is actually able to activate the inflammasome. This has been known actually for quite a bit of time. And again, this is important because of what we believe is a central role of the inflammasome in the inflammatory or cytokine storm. I will not go into all the details, but if you compare the inflammasome reaction in light gray, and you then expose these cells to the next bar in black, which is expose these cells to the protein E of SARS-CoV, you see a much more marked response of IL-1 in terms of the inflammatory reaction. Next slide. Now, why is that important? Well, again, the inflammasome to the extreme right is responsible for the production of IL-1. Once you have the production of an active form of IL-1, this will lead to the production by white blood cells of the second messenger, if you will, which is IL-6, and IL-6, interleukin 6, that you see in the center of the slide, will then order the liver to produce the so-called acute phase reactant, including CRP, C-reactive protein. Now, a few weeks ago, some of you have seen the interesting results with tocilizumab, which is a monoclonal antibody to IL-6. So we were all pretty excited when we saw that if you block the IL-1/IL-6 pathway, that perhaps you can have positive. These results have not been published, but we have seen positive results that if you block IL-6, the requirement for oxygen appeared to go down, and there have been preliminary data from France suggesting that really hard outcomes, perhaps even death, would be reduced if you block the IL-1/IL-6 pathway. Next slide. Now, we told ourselves that if we're right, then the level of IL-6 in blood should probably be able to predict who are those patients who are going to get bad events. And bad events are being hospitalized and ending up in an intensive care unit or even dying. And it turns out that I'm showing you data that have been deposited in the public domain that showed that the patients that actually have these bad outcomes have a threefold increase in IL-6 versus those that do not. And we were also excited by these findings because they support the hypothesis that if you block the IL-1 and IL-6 pathway that is dependent on the inflammasome, that you might have a chance of preventing these bad outcomes. Next slide. And actually, that leads me to this concept of the inflammatory storm. Intuitively, one might think that, well, it is the viral replication that is being at play in the severe lung complications, including viral pneumonia and the ARDS, the acute respiratory distress syndrome. It turns out that if you see on this slide, by the time the patients get these severe lung complications, actually the viral response phase is actually starting to decrease, and actually viral replication has started to decrease. And what's actually causing this severe lung reaction, including ARDS, is actually their host responds to the viral invasion. And so this inflammatory storm, we believe, is probably central to the lung complications, as well as some of the other organs that are being affected. Next slide. very briefly, here are some of the clinical characteristics of the inflammatory storms. They can be responsible for fever and fatigue, certainly the lung complications, including dyspnea, ARDS, but they are also involved in the pathophysiology of the manifestations in other organs, including some of the cardiovascular manifestations, myocardial necrosis, inflammatory cardiomyopathy, inflammatory arrhythmias, but certainly other inflammatory mediated reactions in the liver, kidney, central nervous system, the GI tract, as well as the spleen. As far as the central nervous system is concerned, we know that there can be complications, some of them related to actual infiltration of the virus in the central nervous system, but there are also inflammation-related complications in the central nervous system. Next slide. And so I've told you that our team believes that the inflammatory storm is really central to the complications of COVID-19. And so we believe that by reducing the inflammatory storm that is dependent on the inflammasome, that we might have a chance of preventing the complications. Now, it turns out that there is an agent, colchicine, which is orally administered, inexpensive, that is actually targeting the inflammasome. You all know it because using it in gout and pericarditis. But fairly recently, we have shown in a large study of 4,700 patients, the COLCOT study, that actually colchicine was reducing the ischemic cardiovascular events after an MI, and we have published that in the New England Journal a couple of months ago. Not only colchicine was efficacious at the low dose of 0.5 milligrams that we were using, but next slide, we also showed the safety and tolerability profile of colchicine. If I could have the next slide, please. And so we did not even see a statistically significant difference in terms of diarrhea with colchicine versus placebo. What we saw was a bit more nausea, 1.8% with colchicine versus placebo, 1.0%. Next slide. And so that led us to the concept of launching the COLCORONA study, which is the largest study internationally that is testing the concept of prevention of COVID-19 complications. This is a study of 6,000 patients. These patients need to be 40 years of age or older, being not hospitalized at the time of screening, and they need to have at least one risk factor for the COVID-19 complications. And then they are then randomized to either low-dose colchicine or placebo. What are these complications? Next slide. You have them here. The patients to enter COLCORONA need to have at least one risk factor for these complications by way of being age 70 years or older, suffering from diabetes, hypertension, asthma or COPD, have a history of known heart failure or known coronary disease, or having active fever or shortness of breath at the time of presentation. Next slide. To enter the study, the vast majority of patients have undergone a PCR test, but we also allow a patient that might have a member of the same household having had a positive PCR. If these patients have symptoms compatible with COVID-19 and a member of their household has undergone a positive PCR test, well, these patients can get in. And finally, although we have only a handful of patients like this, we also allow patients that have a probable diagnosis of COVID-19 according to clinical criteria, and you have them on the next slide. So they are very simple. Because we are outside of the flu season, if a patient has the sudden onset of the following symptoms in the absence of an obvious alternative cause, and they are, if a patient has fever and cough, or fever or cough with at least one of the following symptoms: shortness of breath, extreme fatigue, diffuse muscle pain, or the sudden loss of smell, these patients can get in. Next slide. And so in conclusion, COLCORONA is a very special study. It is funded by government as well as both the Gates Foundation and the NIH. The patients can be screened and followed without coming to the hospital. Everything is electronic. I will let Dr. Shah describe that in greater details. The informed consent is obtained electronically. The study medication is delivered at home. Patients can call in the hotline 24 hours a day. You have the number here. This study is randomized, placebo-controlled, well-powered, and is monitored by the independent Data Safety Monitoring Board. So with that, I'm turning it to Dr. Shah, who's going to expand on this and give you the reality of COLCORONA in the tri-state area. Dr. Shah.
Thank you so much. I'm glad I'm coming on now at 7 o'clock. You can hear all the noise made in New York City to congratulate, the first line healthcare workers, and it's really great to hear, but it would be distracting for this webinar. Just to get to COLCORONA NYC, again, we at NYU serve as a local pharmacy depot, and we can deliver within 100 miles of NYU. There are also more sites to come to help extend our reach. Between us and the help of our referring partners, we're trying to capture as many of our community members as possible. Of course, the patient can call the 1-877 hotline. It would be ideal if you could give the patient their GFR value, their most recent GFR value, and it doesn't have to be in the last 3 months or anything like that. Anything within 2019 or 2020 is sufficient. That is the one aspect that does sometimes hold up the patient's enrollment. Of course, if you don't have time to speak to the patient about the study, or if you don't feel like you're comfortable enough to speak towards the study, feel free to email us as well. You can either, again, the patient can just call the hotline, which is open 24/7, or you can email us at COLCORONA NYC. If you just give us the patient's name and contact information, we'll be able to contact them and explain the study, connect them directly to the hotline, help our partners out in Montreal Heart to get the information that they need to help enroll these patients. And it really is a community-based effort. I can't begin to emphasize how helpful how helpful our colleagues have been to help getting their patients enrolled. I've called physicians late at night for GFRs because the time window is cutting it close and their patients are interested. And I've just never gotten any issues there because the community has really come together to help each other, and this is a great way of doing it. We'll have time for question and answer now. I'm cognizant of the time, and so I'm going to pass it over to Michael to allow the Q&A session.
Great. Well, thank you, Benita. And I want to thank all the speakers and those of you who are participating in the audience. As I've been thinking about this problem, I came across this quote from Lewis Thomas that I thought was important to say. Dr. Thomas was actually the dean here at our medical school. He was also a Pulitzer Prize winner in literature, and he wrote some beautiful essays. But one of the things he was aware of is that, is the cytokine storm, basically, that Jean-Claude was talking about. And I thought this quote was lovely. He said, "Our arsenals are so powerful," meaning our own immune and inflammatory systems, "and involve so many different defense mechanisms that we are more in danger from them than from the invaders. We live in the midst of explosive devices. We are mined." And I think that speaks to the notion not that we don't need to treat the infection, but that we also need to be cognizant of our own responses. I have several questions coming up for Dr. Pham, but just before I turn to you, Vin, Dr. Tardif, if I can ask you, since you were the primary designer of the study, can you say a couple of words about your choice of dose and duration of the treatment and why we're treating with what we are treating?
Yes, thank you, Dr. Pillinger. So we chose colchicine 0.5 milligrams for 30 days. For the first 3 days, the drug is given twice daily to sort of have a rapid effect on the inflammatory reaction, much like what we do in gout, for example, or pericarditis for that matter. And then we decrease the dosage to 0.5 milligrams once daily for the next 27 days. So there are a number of reasons why we did that. First, we were strong or felt comfortable because of the fact that we had 4,700 patients from the COLCOT study, where we showed that at that dosage of 0.5 milligrams per day, we showed both efficacy and safety. Second, obviously, if there is one limitation of the use of colchicine, is a bit of GI upset, and in a certain percentage of patients, the development of diarrhea. Now, again, with COLCOT, 4,700 patients, we showed that when we use this particular formulation of colchicine, an enteric-coated 0.5 milligram formulation, we were able to demonstrate that it was not even a statistically significant increase in the risk of diarrhea. So we thought that because we had shown benefits and shown the tolerability of that dosage, that we should use the same strategy. Now, as far as duration is concerned, we had long discussions about this. Our understanding is that one will either develop or not develop a complications probably within the next, within 14 to 21 days after the diagnosis is made. So one might say, well, why did you not limit therapy duration to 21 days, 28 days? We were not entirely certain, but we will basically have one shot on goal, if you will. And we wanted to protect the patients for the full duration of 30 days to make sure that we would not miss some of the late complications. And so bottom line, this is why we are treating patients with colchicine or placebo for 30 days, 0.5 milligrams twice daily for the first 3 days, and then 0.5 milligrams once daily for the following 27 days.
Great. Thank you, Dr. Tardif. I have a few questions here. I do want to be cognizant of everyone's time. We did say we'd try to be done, but if you can bear with us for just perhaps another 5 or 10 minutes, I'll try to have some of these questions answered. Dr. Pham, I have several questions for you, a couple of them practical, maybe one of them a little more philosophical, but here is one question that I want to know. Can children infect adults? So I don't really understand whether children who are exposed become carriers if they don't become sick, or whether they can transit infections. Do you have information on that?
That's a great question. It's still being studied is the quick answer, just like everything else that we're learning about this virus. For a while, there wasn't that much testing of children because due to resource access, then tests were primarily going to folks who had symptoms and were sick in order to determine the allocation of healthcare resources. And so children weren't being tested a whole lot. So we don't really know how many kids had it. We don't really know the natural history of it in them as compared to the many sick adults that we've seen. Clearly they can get infected, and now that we're seeing more cases and identifying them, then we're now hearing about these, again, largely it appears immunologic manifestations, this horrible Kawasaki-like syndrome that children are getting, which again, to the point of this whole webinar, seems to reflect a completely out of control immune response in select individuals. Not everybody, in some. We're trying to figure out why that is. And again, and children, there's more studies now in children now that it's recognized to be an issue for them. But I think that's still a lot of unknowns there.
Great, thank you. And it is, it is fascinating that here we are together, right? An infectious disease doctor, a rheumatologist, 2 cardiologists, and an audience, I'm sure, of mixed physicians. This is really called upon all of us to think globally together. I have a question for Dr. Shah. In respect to the COLCORONA New York City study, what efforts have been made to encourage minority groups to participate, given that they are most affected by the virus?
Okay, sorry, I was on mute. Yes, this is where our referring partners come in and become very important. We want to reach as many communities as possible, and Harlem Hospital is one of those communities. Newburgh Horizon Medical, that covers some of the Bronx, is also one of those referring partners. And it's trying to get the information out there as much as possible. We're working with the New York State Department of Health. We're working through the Health and Hospital Corporation system, and getting access to patients who give their permission when they get their positive results for us to reach out to them. Also, you know, if a patient does not have access to internet, it does not preclude them from the study as long as we can get to them quick enough. We do, you know, we want to put our efforts in the diversity aspect of the study, and we are willing to spend the money to courier over a paper consent with their own pen so that the patient can review in detail in paper. The only issue is that we do need to get to them sooner, not so close to the 48-hour mark, so that we have time to courier over the consent. But we have a courier on standby, and we're willing to do that because we do want, you know, everyone who's eligible for the study to have access to this study.
Thank you, Dr. Shah. And to the audience, I would just add that we've put up our website address, and we've also put up the hotline that you can refer patients to, or you can call yourself 24/7 for information. But certainly we also welcome your help, and we think it's very important to reach out to underrepresented communities. And if any of you have suggestions, we did not put up our direct contact, but you can reach out to us through the hotline, and they'll get to us as well. I think given that the hour is getting late, perhaps we should stop there and let you all go back to your lives. But I want to thank our speakers, Dr. Tardif, Dr. Pham, and Dr. Shah. I want to thank the folks in the background who've helped us organize this. And we certainly welcome your outreach, and we certainly welcome your assistance as well. There are a couple of other questions left here. I don't know if we're able to post them, but one of the questions, Dr. Tardif, as I close out is, we are recording this. Are we going to make this available on the website or elsewhere?
We absolutely will. And we can, if there are a few questions that are not answered during this webinar, we assure you that we will answer all of you. You can write to us on the website, and we will reply to all of you. But the session will be recorded and will be available.
So wonderful, thank you. So I think with that, the hour is late, and we're deeply appreciative for your participation. And we hope to hear from you, and we hope this has been useful to you. Have a wonderful night.
Thank you very much.